Hello, hello. I'm a little late. I started on Facebook and it took me a while. I didn't realize that I have such good involvement on my Facebook regarding antibiotic management, infectious disease, and selection. Hey, Rachel. I wanted to talk real quick about infectious disease, about choice of antibiotic selection, and about what you see when you look at the cultures. So I'm going to talk about different things. I'm going to start off with talking about the differences between, hey, Ja, hey, Cuz. I'm so ghetto and so country when I talk like this. All right, let me calm myself down. All right, let's talk about antibiotic management. There's two major selections that you want to make when you choose an antibiotic selection. Is this a gram-positive bacteria or is this a gram-negative bacteria? So that's very easy to do. I know it sounds, for those who don't do it every day, it sounds pretty difficult, but it's very easy. Gram-positive bacteria, there's only three. That's Staphylococcus, Enterococcus, and Streptococcus. Those are your only three gram-positive bacteria. Now, every form of bacteria has both a sensitive form and a resistant form, and that comes later, and we'll talk about that in a little bit. For purposes for this choice of how do I treat things, let's break it down into two phases. Is this patient suffering with a gram-positive bacteria or gram-negative bacteria, or both? So say you have a patient in a very controlled setting. I always call the hospital a very controlled setting because you got a lot of eyes on the patient. You can control what happens with the patient. If a patient comes in, low blood pressure, high heart rate, 102 fever, complaining of some shortness of breath, maybe the urine smells foul. Good evening, Ms. V. There's a lot of different areas that you have to think about of what could be going on with this patient. This patient is a septic patient. On those patients that come in like that with really high fevers and you don't know what's going on, you don't know if the bacteria is gram-positive, gram-negative, then you treat them with broad spectrum antibiotics, which just means you treat them with both. You treat them with gram-positive coverage, you treat them with gram-negative coverage, and you treat them with atypicals. So for those patients, you would typically see something like a combo of vancomycin, zosyn, and cipro. Those patients, vancomycin is gram-positive, zosyn is gram-negative. It could be gram-negative and gram-positive, but for this purposes, it's mostly gram-negative. And then you treat them with cipro for atypical and those things that are not covered with the two. So when you have a patient that you don't know what's going on, you start very broad. You treat them with everything, and when the cultures start coming back, your blood cultures, your urine cultures, your sputum cultures, depending on what it shows, you can narrow your treatment plan down. So if you have if you're the nurse, if you're not a nurse practitioner and you're a nurse, and you get a critical lab result from the microbiology department that says this patient has gram-positive cocci in clusters, then that's staph gram-positive. So you can, when you look at your sheet, you look at what the patient is getting. If the patient is on vancomycin or any type of gram-positive drug, then you know right away that that patient is being covered. So when you place the call to a physician or the nurse practitioner, you can say, hey, I just got a critical value on the patient. He's growing gram-positive cocci in both sets of blood cultures, but he's on vancomycin, just want to let you know. Then that lets the doctor or the nurse practitioner or the provider know that you also understand about these different bacteria. So if somebody's growing gram-negative bacteria, then you're going to want to cover them with like cefepime, mirum, ertapenem, zosyn. So these patients, when you get cultures back, say it's growing E. coli in the urine and the blood, these patients don't need vancomycin because it's a gram-negative bacteria. So you can treat these patients with, sometimes it's something as simple as Rocephin, which is a cephalosporin, which has great gram-negative and gram-positive coverage, or you can treat the patients with zosyn or levaquin or cipro. Now remember that if it's below the belt and you're dealing with fluoroquinolone, cipro or levaquin, brother-sister drugs, same family. Patient should never be on both. But if the patient has a urinary tract infection, then Cipro's going to be your better drug because it's a below the belt drug. And Levaquin's going to be your better drug because if it's above the belt, because Levaquin does more above the belt. So remember, if you're dealing with gram-positive bacteria in a whole, there's only three forms. So it's very easy to rule out what's gram-positive and what's gram-negative. If it's staph, strep, or Enterococcus, then you are dealing with a gram-positive bacteria. Do not mix up Enterobacter with Enterococcus. Enterobacter is a gram-negative bacteria. Staph, strep, Enterococcus. When you're dealing with staph, when you get back that gram-positive cocci in clusters, that would be before you get an ID and sensitivity, which means I know what shape the bacteria is. I know that this is going to be a form of staph, but what is the drug exact? What is the bacteria exactly? So when you get it back and it says Staphylococcus aureus, that's still that's a good thing to have, but you still want more. You want that sensitivity. If it's oxacillin resistant, then you have MRSA. If it's oxacillin sensitive, then you have MSSA, Enterococcus. If it's vancomycin sensitive, then you have Enterococcus in whatever form it is, whether it be facium or any other. There's multiple forms of Enterococcus. Now, if it's vancomycin resistant, then you're dealing with the VRE. That's when it's termed VRE. And Streptococcus is many forms, but they all very easily cured with penicillins. Now, when you start dealing with your gram-negative bacteria, whether it be Morganella morgani, Stenotrophomonas, whether it be E. coli, whether it be Proteus, the list goes on and on, then you just remember that if you have a patient that you get a call on and it says that the patient has E. coli of the urine and the patient's only on vanc, this patient is not covered. Remember, too, that nothing gram-positive should grow in the urine. The bladder is sterile. We should never have anything gram-positive in there. So when you see that, either it's a contaminant or the patient has a Foley catheter or the patient may have an abscess somewhere in their belly. But look further than just, if you have like a staph in the urine, that's uncommon. Patients should not grow staph in their urine. So either if the patient has a Foley catheter, that explains it. Take that catheter out, repeat that specimen, treat it, because it's always better to err on the side of judgment, but it's probably a contaminant. So for the purposes of today, I wanted to make sure you understood the difference between gram-positive, gram-negative bacteria. What do I treat for my upper respiratory? What do I treat for my sinus infection? What do I treat for my, if I feel like I have congestion, or a cold is a virus, so you don't treat that with antibiotics. Viruses you cannot treat with antibiotics. You could treat them with antiretrovirals, but you got to be careful with that unless you're dealing with the HIV or immunocompromised patient. So for the sake of today, if you're dealing with upper respiratory, amoxicillin as your drug of choice. You could broaden it out a little bit with claviculate, which makes it augmentin, which is a very good drug. But remember, below the belt, gram negatives. Community acquired pneumonia, don't just jump to your fluoroquinolones. Don't jump to your big boy drugs. You want to treat those very, very simple. Don't treat it with azithromycin or doxy by itself. Those drugs need to be in combination. If you're dealing with staph, there's multiple different forms that you can treat it with doxy. You can treat it with clindamycin. You can treat it with Bactrim. But a lot of these drugs, oh, you're back in, Hundy. A lot of these drugs, you just have to know whether or not you're dealing with a gram-positive bacteria or a gram-negative bacteria. And if it's Enterococcus, staph, or strep, then it's going to be gram-positive. And you already know that you could treat with almost any penicillin unless you're dealing with MRSA or something. Skin infections, if the patient has something on the skin, then of course, you're not going to give the patient some amoxicillin. That's not going to be enough. So you want to treat those patients with Bactrim. You want to treat those patients with clindamycin. You want to treat those patients with doxycycline. All of these things are good for Staphylococcus coverage. So if you're dealing with a skin infection, the drug of choice is probably Bactrim, but you got to be careful with Bactrim when you're dealing with the kidneys. And Bactrim is also it's a very good drug, but it's also a drug that you want to watch for Stevens-Johnson syndrome, which can be fatal to a patient. So you really have to have some eyes on the patient and follow that patient when you're treating them with some of these medications. But if it's gram-positive, then you want to treat it with a penicillin or vancomycin if they're in a controlled environment, or something gram-positive. If it's gram-negative, then you can just pretty much do whatever, whether it be Zosyn or ertapenem or Mirum or cefepime or any of those medications. Does anybody have any questions? Chrissy, I had a lot of questions from your classmate there. Do you have any questions today on antibiotic coverage? 3 forms of gram-positive: Enterococcus, Streptococcus, Staphylococcus. Those are going to be your only gram-positive. Everything else is gram-negative. If you're dealing with a urinary tract infection, then below the belt drug, Cipro is a great drug, but just be careful with resistance. Doxy can cover gram-positive and gram-negative. Just be careful. Make sure download John Hopkins Antimicrobial Guide. It's an app you can put on your phone. They're really, really, really good. You can just type the name of any bacteria that you see. So if you're unfamiliar with the bacteria, you can type it into the Johns Hopkins guide, and it will tell you according to body system if there's anything you should be doing, what you should treat the patient with. If they're allergic to this, what's the next best thing, and where it's coming from, and if there's any additional testing. For instance, if you have somebody with a fungemia or yeast in the blood, those patients get very, very, very sick, and you have to treat those patients fast, but they don't get well right away. But for those patients, you have to test their eyes. You have to make sure they have ophthalmic exams because of the yeast that could seed all behind the eyes. You have to test their heart for endocarditis because yeast, along with staph, likes to penetrate the valves of the heart and cause endocarditis. So then you have to treat these patients. Typically, if they don't have any seeding on the valves, you can treat these patients for 2 weeks. You can treat them for a couple of days with IV antibiotics and de-escalate them if it's just a bloodstream infection without heart involvement. But the minute you start getting heart involvement, you automatically change the treatment plan to 6 weeks. So just know which type of bacteria you're dealing with. Gram-positive, gram-negative funguses. And then basically from there, you can go and figure out how to treat it. Gram-positive stuff very easily treated with a penicillin or a form of penicillin. And then gram-negative, you can broaden on to the extended spectrums, such as cephalosporins, or you could treat it with mirum or ertapenem or your carbapenem drugs. There's a lot of different things that you could do for those patients. I hope that helped anybody. I hope that helped y'all. Does anybody have any questions? I always do a better live on Facebook because this is all just coming fresh off my head. And I have a bigger involvement on Facebook. So when I talk, is it Johns Hopkins antimicrobial guide? So almost, it's Johns Hopkins antimicrobial guide. And you can put it in, and I bet you it's going to give you all the information you want. And it's very, what I call dummified. So it's anybody, a lay person can download it and see what's going on. It's not in all that biology and chemistry talk. You'll be able to understand exactly what you need to get out of it. And it'll let you go down. It'll say cardiovascular, brain, abdomen, urine. So it'll point to each body system and tell you exactly what you should be doing and what you should look out for and how long you should treat with this particular bacteria. You can do both at the same time if you use an iPad, laptop along with you. Oh girl, I'm gonna have to text you, and you gonna have to help me be a little savvy. You know, all my kids going out this house, so I don't have anybody telling me about how to stay tech savvy here. So I'm going from one to the other, but that would be nice. iPad, laptop along with your phone. So I'm gonna have to pull my laptop in here and do them together. Does anybody have any questions on antibiotic coverage? When you look at a sensitivity, remember that the numbers you see that says MIC, that shows how much concentration of how many times it took with that particular medicine to get it down to where it would actually respond to the treatment plan. So the lower the number, the more efficacious the drug. So if you have somebody with an MIC of 2, say you're treating E. coli and it's pan sensitive, which means that you could treat it with any of the drugs that it has at the bottom, but one says 8, one says 2, one says 1. Pick the one that says 1. That will be your most efficacious treatment for it. So that means that drug is more sensitive than all of the ones that's been tested to. So make sure that you look at the MICs on those medications, on those sensitivity reports, because they matter. Now, if you have somebody that's on a drug already and it comes back and the patient's responding to it, but something else is a 1, then I wouldn't really change the treatment plan because the patient's responding to it. All righty. Does anybody have any questions? I got a couple calls when I got off Facebook, and I couldn't even start here right away because I had questions that I left off too early. So I want to make sure y'all don't have any questions before I get off. Well, it's been great. I hope that helped y'all out. If y'all have any questions, y'all can definitely just DM me, text me. Y'all have my number. I'm here. Knowledge is power. So I'm just trying to spread some of this knowledge at the simplest form. It doesn't have to be big and amazing. Every little bit counts. So I'm here for y'all. Y'all have a good night.